Thank you, Prof, for the nice presentation and the nice reminder that we need every now and then, and for the small tips regarding the prophylactic use of beta blockers perioperatively and the relation with anemia. We come to the last session in this afternoon before our debate with the simulator. Our next presentation will move to a new group of patients, the pregnant patients with preeclampsia. The topic will be about perioperative cardiovascular implication of preeclampsia. Our Dr. Nuala Locus, hello, she's a postgraduate anesthetic training at the Imperial School of Anaesthesia in London. She is honorary secretary of the Obstetric Anesthesia Association and chair of the educational subcommittee. She serves on editorial board and International Journal of Obstetric Anesthesia. Welcome, Dr. Nuala.
Thank you very much, and thank you once again to the organisers. It's fantastic to be here. So I'm going to run through some of the cardiovascular and clinical implications of managing a pregnant patient who develops preeclampsia. So my learning objectives are I'm going to describe a little bit of the epidemiology and pathophysiology of preeclampsia, and I'm going to present some practical solutions to manage these women if you come across them in your practice. So what do we mean by preeclampsia? I think sometimes people talk about preeclampsia when they actually mean other hypertensive disorders of pregnancy. But really, it's a spectrum of disease, and we're only now, in the last few years, really able to elucidate the various clinical features that go with preeclampsia and to try and define them a bit more. So when we talk about preeclampsia, we sometimes do mean preeclampsia, but even within preeclampsia there are different varieties. But we can also talk, there's gestational hypertension, those women that develop high blood pressure but without the other clinical manifestations of preeclampsia. And lastly, you can have preeclampsia which is superimposed on chronic hypertension that was there prior to pregnancy. Now, as I said, preeclampsia represents a spectrum of disorder, probably at the one end preeclampsia, but in its severe form it can progress to eclampsia. HELP syndrome is now recognised to be another variant on the spectrum of this disease. And lastly, there's an increasing recognition that cardiomyopathy associated with pregnancy also reflects another end of the spectrum. Now, what is the definition of preeclampsia? Well, preeclampsia is defined as new onset hypertension in pregnancy, and it's the new onset that's very critical. And I would urge you all, if your midwife, if your obstetrician says to you, this lady has got high blood pressure, before you say she's got preeclampsia, look at what her booking blood pressure was, because it's new onset hypertension. Proteinuria is frequently present, not always, but frequently present, and a spot protein creatinine ratio is the favoured way to diagnose proteinuria in the UK today. Sometimes you have evidence of biochemical or hematological abnormalities, and sometimes you can have symptoms that are suggestive of end organ disease, and in particular of great concern is fetal growth restriction. We know that preeclampsia is responsible for a huge amount of iatrogenic prematurity. And the American College of Obstetricians and Gynecologists have added on this final point, with or without severe features, to recognise that there is a variation in the clinical features that you will see when you look after these women. So the pathophysiology relates to abnormal development of spiral arteries within the placental uterine border. Instead of a nice low resistance circulation, the spiral arteries are ectatic and present a very high resistance pulsatile blood flow. This leads to chronic ischemia of the placenta, which in turn releases factors which we know are toxic, oxidative metabolites, inflammatory mediators, which go on to cause the end organ disease that we see in our patients. I think I'll whiz through that. Endothelial dysfunction is a very significant feature of preeclampsia, and of course one of the organs that has the most sensitive endothelium is of course the kidney. And that's why the kidneys is one of the first organs to present in a woman who has severe preeclampsia, kidney dysfunction. Now, we commonly say that the treatment for preeclampsia is to deliver the baby, as if once the baby is delivered, it all gets better. And usually, clinically, the woman is well within a few days after delivery. But this is a very interesting study looking at endothelial function. And what they found was that endothelial function could be impaired for up to 3 months after delivery of the baby. So despite our common belief, incorrect perception, preeclampsia does not just go away, and I'll refer back to this point a bit later on. Now, I mentioned that there's an increasing recognition that preeclampsia it represents a whole series of diseases that we haven't yet got to grips with. But I think there is a fairly clear recognition now that there are 2 forms of preeclampsia. Whether or not they're the same disease, and we're mislabeling at the moment, we still don't know, but there are 2 forms of what we currently call preeclampsia. There's early onset preeclampsia, which occurs much less frequently, and it's the most serious type of preeclampsia. You have very early onset sympathetic dominance in the cardiovascular system and elevated circulating markers of endothelial dysfunction. In contrast, late onset preeclampsia, which arrives really just when a woman is reaching term, is much more common, about 80% of cases. And it's often superimposed upon existing maternal conditions associated with endothelial dysfunction. So, for example, diabetes or pre-existing hypertension. Now, the effects of preeclampsia on the heart. If you put this into a PubMed search, or if you're doing any work on this yourself, you will find a whole spectrum of results. The advent of echocardiography, transthoracic echo, has really given us a window into what's going on. But in any 10 patients with preeclampsia, you will find a whole variation in the types of cardiovascular dysfunction that can appear. But I think generally these are features that most people believe are common to the condition, that you will see in the majority of cases. Diastolic dysfunction, reduced left atrial fractional area change and increased isovolumetric relaxation time, reduced stroke volume and cardiac output, and increased total vascular resistance. Now, we know that preeclampsia is associated with very significant morbidity, stroke, severe hypertension, eclampsia, pulmonary edema, end organ failure with the kidneys and the liver, and I've already mentioned iatrogenic prematurity. But I want to say a little bit more about cerebrovascular disease. Now, although it's an extremely rare complication, fewer than 1% of all women with preeclampsia develop a stroke, in women of childbearing age who suffer a stroke, preeclampsia is the single biggest risk factor for stroke. In women with preeclampsia, they generally suffer hemorrhagic stroke, and most tend to occur postpartum. This is a case series of patients from the US analysing the National Inpatient Hospital Database, looking at women who suffered intracerebral hemorrhage in pregnancy. And they found that preeclampsia, the presence of preeclampsia, increased the risk up of 10 times. Now, I just want to mention briefly PRES, posterior reversible encephalopathy syndrome. Now, I have to say that up until about a year ago, I thought, well, this is an extremely rare variant, and I'm extremely unlikely to have to see it. Until I didn't anaesthetize. One of my colleagues anaesthetised a patient with preeclampsia who woke up from their anaesthetic and was blind, which is a very alarming thing to happen after anaesthesia. This differs pathophysiologically from ischemic or hemorrhagic stroke because it is associated with reversible vasogenic edema seen on the CT or MRI. It usually affects the occipital or parietal lobes, and it is thought to be sensitive to hypertensive encephalopathy. Now, it's thought to be related to not absolute blood pressures, but rapid changes in blood pressure. So when we looked back at the anaesthetic chart of this woman, she had a much more labile perioperative course than one ideally would have hoped for. And we believe that this is what caused her PRES. Thankfully, she did recover and her sight returned completely. Now, the management of preeclampsia, there are a huge number of international protocols available, whether you look at the UK website, the American website, the Canadian website. They all offer some excellent protocol-based guidelines for the management of preeclampsia, and I'd urge you to take a look at them. There's much good information there. These patients should be managed on the delivery suite, and emergency blood pressure control is absolutely key, and I'll say a little bit more about that. I'm also going to mention fluid balance and magnesium therapy. Now, blood pressure control. What are we going to do to control blood pressure? Well, I think first and foremost, as anaesthetists, we have the ability to provide fantastic analgesia in the form of an epidural. And there's no doubt that if you have a woman who's in labour with preeclampsia, an epidural, good epidural analgesia can help to keep her blood pressure within acceptable limits. But the questions I want to look at a little bit more closely are what agent should we be using to treat preeclampsia, what route should we be giving it, and what blood pressure should we be aiming for? Well, first of all, if we look at what agent we should be using, what are commonly used agents in Q8? Nifedipine, labetalol, are those the sort of drugs? Okay. So this is a nice systematic review looking at 15 RCTs, more than 900 women, and they looked at oral and sublingual nifedipine versus intravenous labetalol and hydralazine. And I think sometimes there's a perception that an oral drug isn't going to be as effective as an intravenous drug. Certainly as an anaesthetist, it feels much more comfortable for us to give an intravenous drug. But actually, in this review, they found that oral nifedipine was as effective as labetalol or intravenous hydralazine. And there was no difference in maternal or fetal outcome with any particular agent used. So this review didn't say that you had to come down on one side or the other. Both agents, nifedipine or labetalol or hydralazine, were all equally effective. This is a very nice, I think with the constraints of research, I think it is increasingly hard to do randomized controlled trials, but this is a very elegant randomized controlled trial published about 3 years ago now. And what this group looked at, it's a small study, 60 patients, and one group was randomized to receive oral nifedipine with an intravenous placebo, and the other group was randomized to receive intravenous labetalol and an oral placebo. And again, what they found was that oral nifedipine was as effective and in fact more rapidly treated blood pressure in a hypertensive emergency in preeclampsia. So although it may not feel natural for us to give an oral drug, I think you should feel very comfortable, and sometimes it's quicker and easier to get an oral drug out of the cupboard than trying to mix up an intravenous solution. One thing I would say to you is that not all drugs are effective for all patients. So whether you choose to use nifedipine or labetalol, if you don't have success within, and there's no guidelines for this, but I would suggest to you 2 or 3 doses, you need to switch agents. Now, I want to ask you a question. What do you think is more important in this situation, systolic or diastolic blood pressure? Raise your hand if you think systolic blood pressure is more important. And raise your hand if you think diastolic blood pressure is more important. Okay, well look, I think it's the end of the day and everyone's tired, but this is the one point I think I'd like you to take from this talk. Systolic hypertension is the most important factor when you've got a hypertensive preeclamptic patient that needs treating. It directly correlates with the risk of stroke. And in the UK, successful maternal confidential inquiry reports have recommended to treat the systolic blood pressure and bring it down to 150. And we do have good research evidence, although again it's another small study. This is an observational study, 10 years old now, but it's still probably some of the best data that we have, looking at patients who suffered stroke and the change in their cardiovascular parameters. And 95% of patients who suffered a stroke had blood pressures greater than 160. And if you look at these diastolic blood pressures, they were also high, but not of so much concern. So I think the one point I want you to take from this talk is that treat blood pressures of greater than 150, because that's what's going to reduce your incidence of cerebrovascular complications. Now, I mentioned analgesia, epidural analgesia, but sometimes anaesthetists worry about performing epidural analgesia in a preeclamptic patient. I've mentioned the endothelial dysfunction. This is associated with platelet activation, and of course we can have thrombocytopenia. So what we're worried about is vertebral canal hematoma. This is obviously a catastrophic complication for a patient, but I think is equally catastrophic for clinicians these days. We've heard something about medico-legal today, and I think this complication happens. It's catastrophic for the patient who may take legal action. It's rare. The risk factors aren't obstetric patients, elderly patients, patients who are on anticoagulation therapy. And I've said that it's catastrophic. The prognosis is poor in vertebral canal hematoma. There is a limited time to treat. So what stops us doing epidurals sometimes in preeclampsia is the concern about the platelet count. Now this is the very old study that our recommendations are currently based on with regards to platelet levels. They looked at 100 women with severe preeclampsia or chronic hypertension. 26 developed HELP. No parturient in this study had an elevated PT or APTT. Of the patients who had a platelet count of less than 150, 75% went on to develop a platelet count of less than 100. The recommendations from this study was that a platelet count of above 100 was acceptable to do an epidural, and only if the platelet count was less than 100 should you consider doing other adjuvant coagulation tests such as prothrombotime or APTT. And they also recommended only doing serial platelet counts if the platelet count goes below 100. But is that what we all do in our day-to-day practice? Certainly I think that's a very conservative number, and I would consider doing an epidural at quite a significant lower level than that. These are UK recommendations. This is the risk stratification they use. They suggest that with platelets of greater than 100, it's normal risk, so no risk, I would interpret that. There's an increased risk with platelet count of 75 to 100, and high risk at 75 or less. But before I tell you what platelet count I think you should be using, which actually I'm not going to, I'll tell you what I do. I don't know if it's the right thing. I do want to make one other point. There's a big difference between an epidural and a spinal. We know that our epidural needles are much bigger. And so I would urge you, if you really feel unable to do an epidural because you're concerned about the platelet count, a spinal does have much less associated risks because it's a much smaller needle. There's much smaller risk of vascular damage. Now, in terms of what platelet count you should be using, well my personal cutoff is 70, although I would do additional assessments of PT and an APTT, and if this was normal, I would do it. So my cutoff is 70. The other point I want to make is it's not the absolute platelet count, it's the rate of change. So if a woman has had platelet count of 90, 80, 70 over a few, well, you probably wouldn't be, but to say a platelet count of 90 for the last 2 weeks, I'd be very happy with that and I wouldn't worry. But if a woman came into hospital and had a platelet count of 120 yesterday, and this morning it was 90, and it's now 5 o'clock in the afternoon, I'd be much more concerned about that lady because the rate of change of her platelets is much more concerning. So it's not just absolute numbers, it's the rate of change. Now, another reason that platelet counts, epidurals are sometimes, we worry about them, is the risk of cardiovascular compromise, and I'm particularly talking about spinal anaesthesia as opposed to epidural anaesthesia. So our primary anaesthetic goal in a severely preeclamptic parturient is to optimize blood pressure, obviously, optimize uteroplacental perfusion, and to prevent seizures and stroke. Now, historically, we've been concerned about doing spinals in patients with preeclampsia because we've believed that it may precipitate severe hypotension, leading to critically compromised uteroplacental perfusion. So is this borne out by the evidence? Well, this is quite a nice but small review published just last year. First of all, comparing spinal anaesthesia in severely preeclamptic with normotensive patients. And what these studies found was that there was a lower incidence of hypotension in the preeclamptic patients compared to the normotensive patients. So the preeclamptic patients actually got less hypotension than the patients who didn't have preeclampsia. And certainly there was no difference in maternal or fetal outcomes. What about when you compare spinal anaesthesia to epidural anaesthesia? Well, it doesn't perform quite so well. There was a higher incidence of hypotension when spinal anaesthesia was performed for caesarean section as opposed to epidural anaesthesia. But again, there was no difference in maternal or fetal outcomes. So the author's conclusion was that it's very reasonable to perform spinal anaesthesia. And I think that that would certainly be my belief. If I'm really concerned, I may consider doing a combined spinal epidural anaesthetic with a lower spinal dose initially and then topping up with an epidural. But for the most part, I would do a spinal anaesthetic. Now, fluid balance and oliguria. What I want to really emphasise, I think, if I'm allowed to emphasise one more point today apart from the blood pressure, Post-delivery oliguria in these patients is inevitable. If your patient is not passing 0.5 ml per kilo per hour of urine, do not worry. It is almost inevitable in these patients. And continued fluid restriction is appropriate. Remember, they have a very leaky endothelium. If you pour fluids in, you risk causing pulmonary edema. If you're really concerned, and I would urge you to do this anyway, you must always check for the presence of hemorrhage or sepsis as a cause of hypovolemia. But when giving fluids, you have to balance the risks of kidney injury versus pulmonary edema. Now, my personal view, and I think the evidence supports this, is that kidney injury is easier to treat than pulmonary edema. Kidney injury doesn't kill, pulmonary edema does. So I would suggest to you to use clinical judgment, caution, and frequent re-evaluation, and of course I'd urge you to avoid non-steroidals. Now, just to wind my talk up, how to manage an eclamptic fit and how to manage a recurrent eclamptic fit. And this is a very easy question to answer. Magnesium sulfate is the therapy of choice to control seizures. A loading dose of 4 grams should be given by infusion pump over 5 to 10 minutes, followed by a further infusion of 1 gram an hour for 24 hours. And importantly, anticonvulsants, diazepam and phenytoin should no longer be used as first-line drugs. Eclamptic seizures are almost always self-terminating. The reason you're giving magnesium in that situation is to try and prevent further seizures and to halt the onset of the preeclamptic process. You're not giving it to terminate the seizure. It will almost always self-terminate. If you do have a recurrent seizure, what should you do? Well, you should give further magnesium, a further bolus of 2 grams. Now, I just want to tell you about something that didn't happen in my hospital, hospital down the road. It was a normal day on the labour ward, and Mrs. A was being induced at term for moderate preeclampsia. She started to fit, and the whole multidisciplinary team arrived and gave her some IV magnesium. But 5 minutes later, she had a respiratory arrest. Any idea what's gone on there? Any clues? Okay, so what happened there? Mrs. A was a petite lady, and instead of giving the magnesium as a slowish bolus over 5 to 10 minutes, the overenthusiastic obstetric registrar had given it as a rapid bolus over 10 seconds. Because of her relative diminutive body mass index and the 5 grams of magnesium, she suffered acute magnesium toxicity leading to respiratory arrest. She was treated promptly with calcium and she did fine. But just to reiterate, the urge when you've got a fitting patient is to inject that drug as quickly as possible, but you must give your magnesium slowly over at least 5 minutes. So I mentioned the confidential inquiry report this morning. A woman in her late 30s woke her husband overnight calling out in her sleep, followed by a seizure. She was unable to move her left arm. She was admitted, but despite appropriate care, continued to have seizures. Over the next day in the intensive care unit, she continued to have a left-sided hemiparesis. CT scan, performed 36 hours after she presented, revealed a right intracranial hemorrhage, and she died, unfortunately. Neuroimaging should be performed urgently in any woman with hypertension or preeclampsia who has focal neurology and which does not resolve. We've heard a lot today about risks and continued risks, and I said at the start of my talk that we talk about the treatment for preeclampsia being delivery, and that does treat the acute problem, but unfortunately for that woman, the risks do not go away. And we have excellent evidence now that preeclampsia in pre-pregnancy does predispose you to much greater risks of cardiovascular disease later on in life. So just to summarise, our understanding of preeclampsia continues to evolve, and I'm not sure that we will be calling everything we currently call preeclampsia the same in 5 to 10 years' time. Treatment must prioritise BP control. Systolic BP of less than 150 is what you should be aiming for. Watch fluid balance carefully. Thank you very much again for your kind attention.